Afternoon and welcome to today's CPR. And from the Department of Pediatrics, Unit 3, I invite the Pediatric Immunology team, Dr. Kanadam, to kindly take the discussion forward. I think we presented an interesting case of some common symptomatology, but then ultimately reached to a rare diagnosis. Over to you, Dr. Kanadam, to take the discussion forward.
Thank you, ma'am. So today we will discuss the one who presented with the common conditions and remains undiagnosed for a long time and finally diagnosed with uncommon disease. So I invite Dr. Samin to start the case.
Good afternoon. I'm Dr. Saban from the Department of Pediatrics. I'm going to present the case from pediatric pulmonology. The case is an uncommon cause of a common respiratory condition. The name of the patient was Miss A, who is a 12-year-old girl hailing from Muradabad, Uttar Pradesh. She was admitted to us on 19/7/2024 with chief complaints of fever for 3.5 months, along with cough and intermittent respiratory difficulty. In history of presenting illness, she had fever, cough, and dyspnea, which started from April 2024. The fever was intermittent in nature. It was moderate to high grade, which was gradually decreased following medication on OPD basis. It was also associated with cough, which was non-productive, and there was no postural or diurnal variation associated with cough. After oral medications from the OPD visit, the cough resolved for some time, but it recurred even after taking medications after some time. There were also 2 episodes of dyspnea, which were associated with coughing, present only during the morning. After that, there was no such episodes that recurred. She went to a local hospital for 3 OPD visits. After the first visit, her cough resolved for some time, but she revisited the same hospital for recurrence of the same symptoms. After the third visit, she was admitted in a hospital for 11 days due to recurrence of symptoms and worsening of symptoms. There, on radiological examination, there was the ICD was inserted based on the radiological findings. ICD, there was about 400 ml of yellowish colored purulent fluid that was discharged from the ICD. It gradually decreased to scant fluid, which was greenish in color. There was about 10 to 20 ml of purulent fluid discharged per day from the ICD tube. ADT was started in the referred hospital during the first admission, but there was no microbiological evidence, and she was discharged with ICD in situ. She was visiting the same hospital on OPD basis every weekly for the next 4 weeks. After that, as she was not improving, she was referred to AIMS Delhi, and she was admitted to us on 19 July 2024. In other negative history, she had history of weight loss in the form of loosening of clothes, and she also had loss of appetite. But there was no history suggested of any cold, coryza, or skin rash with fluid-filled lesions prior to the illness. There was no history of any neck swelling or abdominal distension. No history of any contact with TB or hemoptysis. No history of allergy or asthma. There was no history of any noisy breathing, sudden onset cough, or choking. No other history of any headache, vomiting, blurring of vision, seizures, altered sensorium. There was no history of any rash or any joint pains. In past history, there was no significant past history for the current illness. In birth history, she was a full-term normal vaginal delivery with a birth weight of about 2.7 kgs. There was the perinatal transition was smooth, and there was no history of any NICU stay. Developmental history, she was studying in 5th grade with good scholastic performance. In dietary history, she had adequate calorie and protein intake before the illness. And in immunization history, she was fully immunized till 5 years of age as per the national immunization schedule. She was the second born child of non-consanguineously married parents, and there was no history of any similar illness in the family. Summarizing the history, she was a 12-year-old girl, premorbidly normal, developed fever and dry cough for 3.5 months, which required chest drain insertion on the right side, with draining fluid being watery and straw colored initially, which later became thicker and greenish in color. Based on the history, the possibilities of complicated pneumonia with right-sided empyema and tuberculosis with right pleural effusion were kept. The points in favor for complicated pneumonia was that the patient was pre-morbidly normal. There was no history of any recurrent infections. There was fever, and there was requirement of chest drain insertion with straw-colored fluid, which later became purulent. And points against the first possibility was that there was no requirement of any respiratory support, and the fever subsided after the initial episode. In the second possibility, the points in favor was that there was history of weight loss and loss of appetite, but there was no history of any contact with TB, and there was no microbiological evidence. On examination, her vitals were heart rate was 90, respiratory rate was 32 per minute. She was maintaining saturation on room air with a blood pressure of 96/68, and CFT were less than 2 seconds. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema, and head-to-toe examination was normal. Anthropometrically, her weight was minus 2.979, and BMI was minus 3.23, showing wasting and stunting. On upper respiratory tract examination, the ear, there was no visible discharge. External ear canal was normal. There was no deviation of nasal septum with no congestion or polyp, and the tonsils were normal along with dentition and gums. In inspection of the respiratory system, there was decreased chest expansion in the right hemithorax, and a pigtail was present in the right fifth intercostal space, mid-axillary line. The right shoulder and the right scapula were at lower level than the left side. On palpation, the inspection findings were confirmed. There was no local rise of temperature, with chest circumference of 62 centimeter, with right hemithorax being 28.5 centimeter and left being 33 centimeter. Transverse diameter was 22 centimeter, was greater than the AP diameter, which was 15 centimeter. Chest expansion was reduced on the right side to about 0.75 centimeters, and the tactile vocal fremitus was increased in the right infraclavicular and decreased in the right inframammary, right infraxillary, and right infrascapular region. The fremitus being increased points towards the consolidation, and the places where it was decreased points that there might be pleural effusion. On percussion, there was dull note in the right infraclavicular region and inframammary, infraxillary, as well as the infrascapular region. On auscultation, bronchial breathing was heard in the right infraclavicular region, suggesting consolidation, with breath sounds being decreased in the right inframammary, infraxillary, and right infrascapular region. There were normal vesicular breath sounds in the rest of the chest, and there were no crepitations or wheeze heard. There was increased right infraclavicular and decreased inframammary, infraxillary, and infrascapular vocal resonance. Other system examination was normal, and the possibilities after history and examination were complicated pneumonia with right-sided empyema and tuberculosis with right pleural effusion. On hematological investigations, the hemoglobin was 10.3, but the main pointer was that there was persistent eosinophilia, with eosinophilic percentage remaining to about 13%, 9.7%, and absolute eosinophil count coming out to be about 1,000, which shows eosinophilia. The biochemistry was more or less normal. Now I call upon Dr. Kaushik for the radiological part.
So initially we have the chest radiographs of this patient. We have 3 points chest radiograph. The initial radiograph is 2 weeks into illness from 27th of April. In this radiograph, you can see that there is a gross right-sided pneumothorax, and not just a simple pneumothorax. Within this, we can see that there are multiple air fluid levels suggestive of septations. There is near a complete collapse of the right lung, except for an air lucent lesion that we can see in the lower zone on the right lung in close proximity. The second scan, we can see that there is an ICD in situ. This is from May 24. There is some expansion of the lung, but there is persistent hydropneumothorax. Again, we can see that there are multiple lucencies within with multiple air fluid levels. The third radiograph is of 20th July, which was at admission to AIIMS. Here, there is persistent hydropneumothorax, there is some expansion of the lung, and there is a collapse or consolidation component seen in the right lower zone, Apart from this, there is again this persistent lucent lesion that is seen in the right lower zone of the lung, and there appears to be some pleural thickening that has developed due to the chronic process. Moving on to the CT scan. So, apologize for the poor quality of images. This is from the initial CT that was done outside, 1st of June 2024. Here we can see that there is a large cavitatory lesion in the right lower lobe with dependent hypodense debris and undulating kind of a surface, which is ruptured and leaked into the right pleural cavity. The contents are leaked, and we can also see that there is a trapped air focus that is seen within the contents of the hydropneumothorax on the right side. And there's a chest drain that is seen in situ at this point of time. This CT scan was done in our center here. This is at presentation to AIIMS on 24th of July. Here there is the pleural thickening has set in, but there is still a persistent right hydropneumothorax. There is a clear communication that is seen between the cavitatory lesion as well as the pleural cavity. And there is a persistent collapse of the medial basal segment of the right lower lobe. Within the hydropneumothorax, there are some hyperdense, there's a hyperdense linear structure, probably suggestive of some membranes. And here we can see that this bronchus, this was the segmental bronchus of the right superior segment of the right lower lobe. That is seen to communicate with the cavity here, and the cavity is seen to communicate with the pleural space. This is so. In summary, this is a case of ruptured pulmonary hydatid in the right lower lobe. We say pulmonary hydatid because of the appearance of the membranes and the dependent multiple fluid levels that we saw on the chest X-ray in the right lower lobe superior segment, which has ruptured and caused a hydropneumothorax in the initial scan. And it has evolved into pleural thickening with chronic empyema and persistent collapse of the right lower lobe, with a bronchial communication of the cavity, which is communicating with the pleural space. So it's forming an indirect bronchopleural fistula. I would like to call 7.
On pleural fluid analysis, the volume of the fluid was about 20 ml, pale in color. There were 56,000 RBCs and TLC was about 25,000. And there was polymorphic predominance along with protein of about 4.1 gram per deciliter and glucose of 26 milligram per deciliter. On serum protein was 8.4 and serum LDH was 333. On pleural protein by serum protein ratio was more than 0.5, and pleural LDH and serum LDH ratio was more than 0.6, suggesting an exudative infusion and a transudative pleural fluid infusion. In the ward, the course of the patient in the ward was the ICT was already in situ, and the fluid discharge from the ICT was purulent in nature, and initially it was about 80 ml per day, followed which she was given injection of ceftriaxone and teicoplanin. Further, the antimicrobials were discontinued after 1 week in view of decreased urine output from the ICT and the fever being resolved. She was started on oral augmentin, and then ATT was continued as symptoms post the initiation of ATT showed improvement. In view of the high eosinophil count and CT findings, the serum ELISA for Echinococcus IgG antibodies was done, which came out to be positive, for which she was started on albendazole. On ultrasound abdomen, there was no hydrated cyst that was seen in the liver. As the lung was not expanding on medical treatment, and there was also associated with crowding and drooping of shoulder on the right side. There was CT scan also showed right pleural thickening and bronchopleural fistula. So the case was discussed with peace surgery, and we decided to go for a thoracotomy with decortication surgery. Now call upon Dr. Priyanjali for the peace surgery.
Good afternoon, everyone. So we plan to take the patient up for OT. So the patient was inserted a double lumen endotracheal tube and epidural catheter was placed. The patient was positioned in the left lateral position and the plan for right posterolateral thoracotomy was made. This is the pre-op X-ray showing the blue arrow pointing towards the thickened parietal peritoneum and the tip of the tail denoted by the red arrow inside the cyst cavity. The objectives and considerations for us were to gain access to the thoracic cavity of the lung for lung empyema and to plan if there is a need for rib dissection. for the removal of parietal thickened peel, also to remove the visceral thickened peel. Another objective was to suction out the contents of the cavity carefully and to close the bronchial leak, also to manage the residual cavity. So these are the intra-op images where you can see two instruments, the forceps pointing towards the thickened excised parietal pleura, the back-top forceps holding the visceral pleura over the lung parenchyma of the right lobe. Here we can see the cyst cavity in the apical segment of the right lobe with the normal lung parenchyma. The similar intra findings are more clearly visible in the adjacent image, where we can see the cyst cavity communicating with the apical segment of the right lower lobe with visceral pleura overlying the lung parenchyma and the excised thickened parietal pleura. So intraoperatively, the rib dissection was not needed for this patient. Both the peels were removed. The cyst contained necrotic purulent material, which was evacuated carefully using a suction catheter. The bronchial communication was located and was closed. Overhanging margins of the cyst was removed, and capitonage was done to close the cyst cavity. ICD was inserted, and the patient was extubated and shifted to pediatrics ICU. Here is the video of lung expansion post removal of the thickened visceral pleura, which we were unable to achieve preoperatively with ICD insertion. Thank you. Now I would like to call this will be for discussing the histopathology.
Good afternoon. We had received parietal and visceral pleura for histopathological examination, and it showed fibrocollagenous tissue with large areas of necrosis, which were walled by thin rim of palisaded histiocytes, along with that large areas of fibrosis and chronic inflammatory cell infiltrate was noted. Eosinophils were also present in the inflammatory infiltrate. On special stains, no fungal profiles were highlighted on the PAS stain. However, on Zeal-Nielsen stain for acid-fast organism, we saw hooklets of Echinococcus, which thereby confirmed the pathological diagnosis of hydrated cyst.
Further course in the ward, she was extubated post-op on the same day before being transferred to the PICU for monitoring. She was hemodynamically stable in the PICU, and so she was shifted out after 1 day. Post-op investigations, lung aspirate for GeneXpert was sent, which was negative for Mycobacterium tuberculosis. Tissue biopsy for gram stain and culture revealed Stenotrophomonas maltophilia, which was pan-sensitive, for which cotrimoxazole and levofloxacin was added. Before surgery and after surgery, there shows the clear lung expansion. And the final diagnosis of complicated hydrated cyst of the lung with pyromothorax was made. Course in the ward, the ICT had a bloody discharge for 2 days post-op, which later became clear with decrease in volume. ICT was removed after day 6 of the surgery. She was being administered analgesia by the epidural catheter that was placed in situ, and which was also removed on day 6. She developed fever, for which cefoperazone sulbactam was given. She was afebrile for 48 hours, and blood culture was also sterile. ATT was discontinued as there was no clinical, microbiological, or histopathological evidence of TB, and alternative diagnosis was already established. She was discharged on albendazole, which has to be continued for the next 6 months. Now I call upon Dr. Mark.
Hydatid cyst occurs in children, about 10 to 20% of children, and it usually occurs due to spread from hematological route. Rarely it can spread by lymphatic circulation as well. Most commonly located site is lung, which is about 64%, and followed by liver, where it is 28%. Hydatid cyst can be easily symptomatic because of the compressibility of the lung tissue, high vascularity, and lower negative pressure. And hydatid cyst can grow up to more than 5 centimeters per year because of high compliance of the lung and flexibility of the lungs. In a study done in Turkey, where 94 children were taken, it was found more common to have symptoms of cough followed with chest pain and fever. There were also documented hemoptysis and expectoration of daughter vesicle as a form of grape-like material, and also anaphylaxis also was rarely noted. With respect to the organ involvement, it was more common in the right side, and the serology was done in as in our case also. Here, the positivity was found to be only in 32% of cases. And most common complication, what they had seen in the early stages, were prolonged A leak for more than 7 days. And those with ruptured cysts, the most common, there also the serology positive was only 4 and the cyst dimension, what they noticed was less than 10 centimeter, were more prone for ruptured cysts. Another study done in 63 children, again in Turkey, where the ruptured hydatid cysts where children were studied. The mean age was found to be 12.3, where our case child also was 12 years. And key symptoms, as we have discussed, were more of cough, and radiologically there was hydropneumothorax, air fluid level, and total pneumothorax found in the order of frequency. And this study also showed that there was most common operative method being cystotomy and capitonage, and complications were not only extended air leak, empyema, and bronchopleural fistula. They were also noticed to have mortality, and this mortality was noticed in cases who were operated beyond 4 days after rupture. And what they found that single lung ventilation reduced the complications, and hence they suggested early surgical intervention within 4 days of rupture, and try to preserve maximum lung parenchyma which is possible, and avoid transthoracic needle aspiration for diagnosis. The complications, what they noticed post-op was extended air leak, empyema, bronchopleural fistula, atelectasis, pneumonia, and even hemoptysis, sepsis, and aspiration of the hydatid material. So one study, similar case report, which was reported from another part of this country, was in a young adult who also was initially treated as pneumothorax with bronchopleural fistula and treated for ATT with ATT for tuberculosis, and was referred to one pneumonectomy. But on the table, they found during decortication, a ruptured hydatid cyst was discovered. And finally, they had done capitonage of the ruptured cyst, and a floor wall was also repaired to overcome the bronchopleural fistula. In the management of hydatid cyst, the main backbone is the conventional surgery. The aim would be to remove all parasitic substances, close the possible existing bronchopleural fistulas, and preserve the lung maximum tissue, especially in children. There are many techniques which have been described, which includes open enucleation, pericystectomy, cystotomy, and capitonage. Cystotomy without capitonage, segmental resection, and lobectomy, which is decided case-to-case basis. Another medical management which is important is preoperative albendazole, where nowadays is not preferred because of cyst rupture, wall rupture. Post-operative albendazole has been recommended for 3 to 6 months, both by WHO. It is also been described to use as per case-to-case basis, and to monitor when albendazole is given with respect to especially LFT, liver function test, and CBC. And there can also be a reversible hair loss, which will resolve after stopping of albendazole. And albendazole dose is 10 to 15 mg per kg, should be given with fast rich materials in 2 divided doses. So ultimately, the take-home message is ruptured hydatid cyst can present in an unusual way as pneumothorax with bronchopleural fistula. Correct diagnosis can be missed and can be confused with pulmonary tuberculosis with superadded empyema. The clinical suspicion, especially eosinophilia in our case, may be useful for diagnosis early, and judicious exploratory thoracotomy and decortication along with repair of fistula help to salvage the lung. Thank you.
Thank you all residents. So when you see the case of the pneumothorax, and most common cause are the staph aureus or the gram-negative bacteria like E. coli, Klebsiella. This side, initially they managed the bacterial pneumothorax, but later on started the ATT without any mathematical evidence. This side has a few clues, as we discussed the persistent eosinophilia. In any child with persistent neutropenia, we should look for the causes why there is a persistent neutropenia. Second, if we interpret carefully the imagings also, so there are some clues that suggestive other than the pyrolymphatic also. That's why we were able to do the effective diagnosis and then do the management of the child. So now the case is open for any questions and the comments. So dyspnea might be because of the dyspnea was even after the part of the cough. So because by pneumothorax might have worsened during the cough, that may be reason for the this transient worsening of the pneumothorax may be reason for the this transient episodic dyspnea. It may be spontaneous recovery. So if I transient only after the out of the cough, there transient dyspnea, then again the decrease in the dyspnea. Yes, no plain language. Also there we also discussed that we say in the pediatric surgery ki how to go about the surgery because are there risk of the dissemination of the other part.
So in the undergraduate system, we are very, very cautious about a lot of things that we have to do for that area of inside the agents, and then they will expose a very limited amount. But in a budget sense, in this case, it will be just because we have to do both the practical the patterns, the very we do daily work. So for us, this case, probably the
Yes, ma'am. It's more common than lungs. Yes, yes.
it's most common.
It will be because we see the only the lungs. So we are planning to give the for 6 months. Although they know very well that mostly say that between 3 to 6 months. So even child came after 3 months or around 2 months. Already 2 months done. We opened in the other in July. So 2 months completed. We are planning to go total 6 months. Any other questions, comments? Sorry? Brain identity because the child has not any symptoms for the any symptoms, so we didn't look for any. No problem. It may be possible. I am not aware. Then we can close the case. Thank you all. After any comment for